And yet you hear all this dialogue about electronic health record. We'll talk about that further. Invest in prevention, treatment, and recovery support services. Ensure a safety net for people with the most serious and disabling mental health and substance use conditions. Our priorities at CSAT are consistent with the core principles. Promoting health IT. We have to be able to share information, not be in a situation where a chart has to be recreated every time a person is seen. We need to promote accountability and performance measures. We need to demonstrate that what we're doing is making a difference. Evidence-based practices, expanding capacity and integrating substance abuse treatment, recovery, health, and wellness into primary care. Expanding access to medication-assisted treatment. We still have, despite all of the research that says this works, we have people walking around saying, it is my philosophy, my personal belief, in my heart, my gut tells me. Poor old Tim Condon out there is pouring millions of dollars into research, developing evidence-based practices, and people are running around, my gut tells me. Hello? We have to continue to enrich our partnerships with state agencies to advocate for mutual concerns and initiatives to the federal government, and we have to make sure that our community providers are actively involved in the dialogue. You see the problems, you're working with the problems, you see the people, you know what their complex issues are. We need this bidirectional flow of information. Health information technology. The president says we'll computerize our healthcare system at last to save billions of dollars and countless lives as we reduce medical errors. If we're not a part of this process, we won't have comprehensive management of information, secure exchange. We won't be able to protect privacy. HIT results in public health benefits, earlier detection of infectious disease, but from our perspective, early detection of changes in the epidemiology of substance use disorders. I remember as a provider, as a treatment provider, when methamphetamine came along, we said, gee, there's all this methamphetamine. And you looked at the literature, there was no reference to it. Oh, when you guys see people as the behavior changes on the ground, we need that information. Improved tracking of chronic disease management, evaluation of healthcare based on value, enabled by the collection of de-identified price and quality information. That's right, we will have to compete. But guess what? There are 20 million people who are not showing up for treatment. The reason we're competing, we compete for the waiting list. Oh, yeah, 380,000 people. That's the waiting list. 20 million people standing in the wings drinking and using saying, I have no problem. Yet they meet criteria for having problems. So they are in denial, their families are in denial, the employers are in denial, law enforcement, oh, there's George, it's his 5th DUI. Well, we'll wait until his 6th one before we really up the ante. We need to be dealing with these issues. Our goal with Health IT is to accelerate the use of effective health information technology to improve care, outcomes, safety, and value, reduce duplication, enhance coordination, facilitate standards, recommend care, and reporting and transparency. Now, the stimulus package, many of you have heard about the stimulus package. You don't hear much from SAMHSA about the stimulus package because we didn't get anything. We got decimal dust. No, we didn't even get decimal dust. That's right, we didn't get decimal dust. Knight over there, Knight got money, and I don't begrudge them their money. I could drool in envy, though. But the key issue is that the health IT proposals are going to focus on physicians and hospitals and not on substance abuse and not on behavioral health. But it does not mean that we can stand idly by. So Ann Herron's group and others within CSAT are pushing our involvement in health IT so that you are at least contemporary, so when your states move to adopt health IT, you're ready for prime time. We have to be ready for prime time. That allows us to move toward accountability and performance. In these economic times, people want to know that what you are doing is making a difference. You can have all sorts of ideological and philosophical and visceral responses to something, but people want to know, are you actually helping somebody? Back in the day, we used to blame the person. When treatment didn't work, quote unquote, didn't work, well, it was the patient's fault. And we continued business as usual. Now people want to know, well, maybe the patient should have gone to should go to a different program next time. National outcome measure data are being used by CSAT to monitor the effectiveness of our programs and progress toward achieving national goals. Such data help identify areas of improvement and provide evidence of success. And I can tell you that has affected the Congress's reaction to SAMHSA tremendously. We are presenting data and outcomes. We can quibble about the particular outcome measure, and we can quibble about the level that you should get some outcomes, but at least we have the data. We need to keep that in mind. And I want to thank the Action Campaign for moving in the direction. Currently, 9-star SI states have demonstrated a 16% increase in outpatient admissions. Increase in admissions means more income. 24% decrease, observed a 24% decrease in wait time. Decrease in wait times means more quality and accessibility. People have access to treatment. 6 ATTC and 2 ATR grantees are implementing state-level NIATx projects. 8 PPW grantees have increased family participation by 130%. NIATx is initiating projects to improve coordination of care and recovery support, SBIRT, HIV/AIDS, opioid treatment program, and criminal justice programs. We don't necessarily need a large infusion of cash to be ready for prime time. I mentioned the PPW program. I threw this slide, it wasn't put in by my staff, but I thought it was very important. Our PPW program, the president says, I'm interested in responsible fatherhood. Well, one of our PPW programs is adopting NIATx strategies. Oh, it turns out they're increasing father participation in their pregnant and postpartum women's program. That's what PPW stands for. Pregnant and postpartum women with kids from 15 to 25%. They're offering conjoint therapy, family classes, and supportive therapy, increasing responsible fatherhood. You have to do something. You can't say, well, we need a major new initiative. Well, you give us $200 million and we can achieve your goal and objective. You'll be standing out there by yourself. Standing in Tucson at high noon. With a Parker on. We're producing changes using evidence strategies that don't necessarily cost a lot, just a commitment. People are worried about the economy. You earn money by making the necessary change. You increase your admissions, you increase your income. Hello? You keep people in treatment, you retain people. You don't do the most expensive stuff. The most expensive stuff is that admission stuff. Got to evaluate you, got to order tests, got to do a physical, got to do this, got to do that. Every client who drops out of treatment after 2 sessions, we have a 50% no-show rate without some kind of intervention, and we have people who drop out after 3 or 4 sessions. Well, we go back and reinvent them. Next client, please. We got issues. We need evidence-based practice. The National Quality Forum Standards for Treatment of Substance Use Conditions includes NQF is a public-private healthcare partnership that endorses performance measures and other standards to improve healthcare. In 2007, they approved a set of 11 fully specified evidence-based practices for the treatment of substance use conditions. These standards were developed, have federal legal status in accordance to the National Technology Transfer and Advancement Act of 1995, and this is the cartoon in terms of their evidence-based practice, identification of substance use conditions, screening, case finding, diagnosis assessment, initiating and engagement of treatment, brief intervention, supportive services, withdrawal management, therapeutic interventions to treat substance use illness, psychosocial and pharmacotherapy, and continuing care management of substance use illness, long-term coordinated management of substance use and coexisting conditions.